first guest is a busy man, and he's been a particularly busy man or minister this week with a major shake-up in public health in New Zealand. The removal of the Te Whatu Ora board, their replacement with Lester Levy as a commissioner for a year, and really a huge shake-up. We were told Monday post-cabinet that Health New Zealand overspending by an eye-watering $130 million a month. That's the overspend, folks, not the total budget spend, the overspend, $130 million a month. So what is going on? And following on a very interesting discussion we had yesterday with Professor Des Gorman, is there a plan to replace whatever is going wrong and fix whatever is going wrong at present? To find out more about this, we are joined now by the Minister of Health, Dr. Shane Reti. Dr. Reti, thank you very much indeed for joining us by video link this morning. Good to see you.
Hey, good morning. Good to speak with you too.
All right. Look, first up, is this part of an already strategised plan to fix these problems, or is this first up just a case of stopping the bleeding if you can?
So it's a combination of things. First of all, we've got to repair before we can build. So yes, we definitely do have to stop the bleeding. And it's not hard. New Zealanders will understand that the biggest health reforms in 20 years were always going to be tumultuous. I would raise the question, you do this in the middle of a pandemic, what sort of outcome did we think we were going to get when you do the biggest health reforms and you do it with that sort of timing? So the implementation has been a real struggle for this government. They brought it on themselves the way they went. I remember here maybe amalgamate 8 to 12 and then look to iterate from there. But no, a previous government decided, no, we'll throw all 20 DHBs together and good things will happen, and clearly it hasn't. So there is the place here at the moment to stabilise, rather than stop the bleeding, to stabilise the sector. And that includes hearts and minds. Morale is low. The number of people who have come out since I made the announcement, clinical people, and said, thank goodness, I sense a ray of hope again. So it's important that we have hearts and minds in the sector as well. But a lot of work to do here. And Professor Levy has been tasked and developed a plan that we've looked at to help turn this around, return the decision-making to the front line. So if we really look at the why, to me, the issues have been a complete disconnect from the front line. Clinical performance had plateaued, and then, of course, the financial position had deteriorated as well. That's the why the board needed to be changed in place of a commissioner.
Des Gorman said to us yesterday, and he said to us 2 years ago, the problem with these reforms was there weren't benchmarks and targets for what the reforms were meant to achieve in terms of delivering health outcomes for New Zealanders and efficiencies for New Zealanders. There was nothing to measure success against because they seem to be ideologically driven changes. Do we have, and where can you point us to, the benchmarks you are going to use for success of your administration in fixing this problem?
Yes, look, I think Des is right, and this was a key feature coming through the campaign differentiating from the previous government. They specifically said that targets would not be at the forefront of their health policy. I very clearly said targets would. And so about 2 weeks ago, I announced the government policy statement, which is the direction of travel for health, where health will go. And in that, I have a number of targets. More specifically, I have 5 top-tier targets, 5 modifiable behaviours and 5 pathologies. And those 5 top-tier targets that we'll hold ourselves accountable for include wait times for surgery, wait times to see a specialist, wait times for cancer, emergency department wait times, and immunisation. Those are the 5 top-line targets. We know what the baseline is. Our baseline started on 1 July. That's our measure. We know exactly each quarter where we need to be, and we know when the end point will be, what the goal is we're trying to reach. Underneath that, the preventative stuff, which is really important, that's what keeps people well and stops them getting into hospital. We'll focus on smoking, we'll focus on alcohol, we'll focus on diet, exercise and social cohesion. And underneath that, the last 5 talk about pathologies that will be important. That'll be cardiovascular, respiratory, diabetes, cancer and mental health. That's it. That's what we're going to do really, really well.
And in broad terms, you are going to move slightly away, but not all the way back, to a decentralised model. We are going to have what we would have traditionally called DHBs but covering far larger areas and what, if you like, natural catchments of patients and communities of interest?
Yes, well, we'll move back towards regions. We want to return that decision-making to the front line. So in about 10 days, the regions will receive budgets, they'll receive decision-making, they'll receive commissioning, they'll be able to respond more to local needs rather than the layers and layers of management that regions had to push through to try and get their voices heard. So we will return to 4 regions in very, very short notice.
Okay, so just 4 regions. What are they going to be? Can you give us a broad outline where they are?
Yeah, sure. Those regions in geographical terms will be northern, up in the northern region, mid-central, which swath across from Palmerston North through across to Hawke's Bay, central, which will be the lower part of the North Island, and southern, which will be all of the South Island.
Right.
And roughly, in fact, there are 4 regions here now, actually. So it will stay that way at this point in time, although we are looking at some shifts, particularly following the cancer trail, where it may make more sense for some district hospitals to be maybe in a slightly different region. But that will be the core of the 4 regions.
All right. Well, it sounds like there is a plan there, which is kind of encouraging, because I think a lot of people would have read the headlines on Monday or Tuesday morning and said, oh, the thing's just a mess. Is there a plan to get out of it? And it sounds like you do have one. Can you tell me where that $130 million a month was bloody going? It's such an eye-watering figure, Doctor.
Well, it is. And what's even more disappointing was how late it was picked up. And, the Auditor General had pointed this out for quite some time. No one is watching. There is no internal performance monitoring framework. So imagine in February, I'm reported to from by the way, Minister, the 583 million surplus that we think we're going to reach, we're on target. 30 days later, it's a surprise, we've got a $100 million deficit. And the next month it was 130 million. No one was watching. There were no structures in place. And they'd been warned. You don't have an operating model, you don't have an internal performance monitoring framework, and no one did anything. So there's the lack of watching, the lack of robust structure. Where the costs themselves went to were several areas. Workforce, both frontline and back office, were an issue. Frontline, an increased, which on one level is a good thing, but it needs to be of the right type. So, for example, we're still very short of mental health nurses, maternity nurses, critical care nurses. Secondly, it wasn't always in the areas that we need them. I'm pleased that North Shore is relatively to quota, but that doesn't help those out in the regions in Northland and in Invercargill and Hawke's Bay, so they weren't in the right place.